So in the next few minutes, I'm going to try to address this topic of recurrent and persistent metastatic lymph nodes in patients with differentiated thyroid cancer. And I'm going to try to show you what we know, what we think we know, and what we don't know. So some facts about this entity. We know that following surgery, whether the patient does or does not receive radioiodine ablation, about 1/3 of the patients will in the future develop cervical lymph nodes, which a small minority will prove to be malignant and very seldom will progress. We also know that there is no prospective randomized trial with long-term follow-up showing disease-related survival or disease-specific survival benefit for early surgery in this clinical scenario. My impression also is that many of the recommendations of what to do with lymph node metastasis come from what we know on the metastatic nodal disease during presentation of differentiated thyroid cancer, not necessarily in this clinical scenario of recurrence. The studies on the efficacy and safety of surgery in regional and recurrent disease and persistent disease, like maybe the case in our patient, which 1 year after surgery also already has lymph nodes, well, these studies are not homogeneous in their study population. They're mostly retrospective, not mostly, but almost all are retrospective. They report on biochemical and sometimes also on structural cure. The way they define biochemical cure, whether it's stimulated or non-stimulated thyroglobulin, is different. And they mainly don't have long enough follow-up in order to prove that there is any effect on disease-related survival, which we are looking for in order to support such an attitude. So what is the clinical significance of metastatic cervical lymph nodes in differentiated thyroid cancer? I don't know why this slide is going on its own, but it is. So help. But what we know is, and this has been already introduced earlier, that in a stage 1 patient over age 45, the occurrence of central neck level 6 positive lymph nodes on pathology will upstage the patient from stage 1 to stage 3. And similarly, if this is a lateral neck lymph node, then the patient will be N1B, and this will upstage them to stage 4A. And we are all very familiar with the paradigm and with facts that increase in stage translates to worse prognosis. And that's what gets us excited and worried when a patient comes with these lymph nodes. We also know that in the AATA risk stratification for recurrence, the occurrence of metastatic cervical lymph node increases the risk for recurrence, and the patient is moved from the low risk with a 6% chance of recurrence to the intermediate risk group with 21% chance of recurrence. But the question is, are all metastatic lymph nodes in differentiated thyroid cancer created equal? And I'm going to present in the next 2 slides a review that was prepared by a task force for the ATA. The first author is Randolph, and our guest, Professor Tuttle, is last author. On all that we know about lymph nodes in the context of differentiated thyroid cancer, but I want to stress that most of these studies are not dealing in the context of our patient with recurrent disease, but rather with any nodal disease, usually at presentation. And you can see here the different references that they used as source to calculate a median and a range of chances of recurrence according to different characteristics of the lymph nodes. And I want to introduce a term that's familiar to most of you, which is clinically apparent lymph nodes. These are lymph. It's also initialized CN1, and it's identified either by palpation, by imaging, or by intraoperative inspection. So it's not something incidental that you run into when you do prophylactic compartment surgery. It's something that you were suspecting. And just having clinical N1 disease raises the rate of recurrence from 2%, from clinical N0 to 22% if it's clinical N1. In addition, they were able to show from the various studies that they reviewed that if you have less than 5 metastatic nodes, you will have a median of 4% chance of a recurrence, while more than 5 increases the chances by 5, so it's 19%. And I want to point out another important bad prognostic sign, which is a pathologic sign. It's extranodal extension that actually this gives altogether the highest rate of recurrence. And I remind you again, this is something that we can only get by pathology. So taking all these studies together, they divide lymph node metastasis and DTC, which are, by the way, not created equal, into a low-risk and a high-risk group. And a combination of these characteristics, if it's clinically detectable, if it's a large metastasis, and if there are more than 5, you're in the high-risk group, more than 20%. But if you're But if all the others, for all the other situations, it's considered low risk. So this was just an introduction about the significance of lymph nodes in the context of differentiated thyroid cancer. Now, when we go to address our specific scenario of recurrent or persistent disease, and we look at the guidelines, so I hope I'm not doing something illegal by showing a draft copy of the of the 2014 ATA guidelines, but mainly if we compare the two, the recommendations from 2009 to the upcoming 2014, which already had to be published, you see that in 2009, the ATA said that therapeutic, comprehensive, compartmental, lateral, and or central neck dissection sparing uninvolved vital structures should be performed for patients with persistent or recurrent disease confined to the neck. And in the small, details of the recommendation, they mention a size of above 5 to 8 millimeters, and there's no differentiation whether it's a level 6 or a level 4 node. In the 2014 guidelines, this is the recommendation itself that recommends surgery for central neck nodes greater than or equal to 8 millimeters and lateral neck nodes greater than or equal to 10 millimeters in the smallest dimension. And I'm going to go back to this in a little bit later. So there is a little bit of a shift. The size has grown. And if you read the details, then you can actually be exposed to all the dilemmas and the conflicts. And we will, both of us we'll be bringing them up a little bit later. And looking at the British guidelines, there actually is no size limit there. They are talking about clinical recurrence in the neck and giving the different considerations if you should operate or not. They don't give a clear-cut answer. And what I want to spend the next few minutes is to show you two publications that came out in the past few months that deal to the point with our clinical scenario. One is written by Mark Orkin from Mount Sinai as the first author, and there is also, again, Mike Tuttle is the last author on this one. It's actually a multifactorial decision-making guide for the Thyroid Cancer Care Collaborative on the management of recurrent and persistent metastatic lymph nodes in well-differentiated thyroid cancer. And in parallel, and some of the authors are co-authors on both publications, there was another review that was written for the ATA task force on nodal disease and the management of recurrent and persistent nodal disease in patients with differentiated thyroid cancer. It's a critical review of the risks and the benefits of surgical intervention versus active surveillance. And the reason I'm showing you these studies and not going into the details of all the specific studies that show the effect of surgery in this clinical setup is because they review this for us. And also because they tell us as clinicians, okay, so what do I do with all this data and how do I make a decision with my specific patient? So as I mentioned, both reviews summarize very nicely the outcomes of reoperation for recurrent or persistent lymph node metastasis in thyroid cancer. You can see that the studies that they summarize, they review encompass the years of 2007 to 2012. Every one of these studies had more or less 100 plus minus patients, and most of them, as I mentioned, if not all, were retrospective. You can see that the length of time of follow-up following the second surgery was variable, with the largest being in this series by Clayman. It was up to a mean of 87 months, but some were much shorter. You can also see that the time interval between the initial surgery and treatment and the recurrence was about between 2 to 3 years in the series that reported this time interval. And now I want to take you in terms of the outcomes. So we spoke about biochemical cure, which is defined by thyroglobulin levels, and you can see that some used stimulated and some used unstimulated, and every one of them had also different cutoff values in order to define a patient as being cured. And each study, using its own criteria for biochemical cure, reports their percentage of patients in biochemical remission in this time of follow-up that they had, which is not very long in the context of differentiated thyroid cancer. And you can see that the mean is about 50%. So our ability to biochemically cure a patient with persistent neck disease in terms of thyroglobulin is only 50%. We are much better in terms of anatomic structural disease, with more than 80% of the patients free of ultrasound positive disease in the neck following recurrent surgery. And I just want to mention that some of these series, the patients were reoperated more than once in order to receive biochemical cure. So this is in terms of the outcomes. In terms of the complications, again, these are the various studies. And you can see we're always concerned about permanent and unexpected nerve injury. It's up to 6.4%, which is not, in some of the series, it's very similar to the first operation. And in terms of permanent hypoparathyroidism, again, there's a wide variety. in these different surgical series up to 9.5%, which by the reviewers is considered to be reasonable in the context of this disease. So what both papers do, and this is why I like them, despite the fact that I'm supposed to convince you that surgery is the answer, well, both reviews very elegantly went through the different considerations that we should have in mind when we make the decision with the patient, because there is no right answer, one right answer for this clinical scenario. So first and foremost, they recommend that we look at the lymph node characteristics. What's the absolute size of the lymph node? This is also reflected in the 2014 guidelines. If the lymph node is in the lateral neck and it's less than 1 centimeter, or in the central neck and it's less than 8 millimeters. And here, by the way, the reviewers commented on any diameter, not just the short axes. And the reason there is a difference, we all know that as lymph nodes in the neck become malignant, they lose their oval shape and they become round. And that's why we're interested in their short axis diameter being a prognostic sign for malignancy. But according to both reviews, you should look at any diameter. Calcifications obviously make them more suspicious for malignancy. The rate of growth based on serial imaging, and again, after reviewing the literature, they put up a cutoff of more or less than 3 to 5 millimeters per year as being the cutoff to decide that the disease is more aggressive and it justifies surgery. Location of the nodes, these are surgical considerations. If, for example, the patient has already contralateral vocal cord paralysis, and now he has a lymph node that's risking his ipsilateral right recurrent laryngeal nerve, some would advocate that you should operate before the recurrent nerve will be damaged. Similarly, if there is invasion into or proximity to critical anatomic structures like the esophagus, blood vessels, that would encourage you to send the patient to surgery. And as I've shown you before, the number of the suspected lymph nodes also is important, telling us about the aggressiveness of the disease. About the patients, we want to know a little bit more about the patient's thyroid cancer. What is the rate of change in thyroglobulin? If it's stable or slow versus a doubling time that's less than 1 year is considered slow. But if it's higher, then this usually is an indicator of aggressiveness. Are there any known metastasis, systemic metastasis? Because in this situation, there's not much of a point of operating the neck unless you're concerned about local regional complications. What was the response and the complications to previous treatments? Mainly, you want to know if this compartment has been dissected previously, because scar tissue makes a reoperation of the same compartment more complicated. And we want to be sure that we know what the long-term disease-related prognosis of the patient is, and usually it's very good. In terms of the primary tumor pathology, was there aggressive histology? Usually this is a more aggressive tumor and will go into surgery more easily. The stage of the disease, and again, extranodal extension in previously dissected lymph nodes, again, is a harbinger of more aggressive disease, and I will allude to this in just a little bit. So last but not least, it's the biology of the tumor. Was it iodine avid? Then you can wait, because you have other treatment options, but if it's FDG avid, it's usually more aggressive and you want to send the patient to surgery. BRAF mutations, and far and foremost are the patient-specific criteria. His comorbidities for surgery should be considered, his age, not only biologic age, but also chronological, but also biologic age. And this has been stressed several times before, and I truly believe it is very important. What is the patient's concern from watchful waiting versus his willingness to go into operation again? And many of the patients have a very, very hard time to live with the concept that they have a chronic disease that's going to stay like this in their neck, and they're not going to die. And it's sometimes very hard to convince the patients, and they're the one pushing us to take the next step and to go into surgery. And last but not least, obviously, your own surgeon's experience should be another point that you take into consideration when you decide if to send the patient to surgery, or resurgery or not. If we decide to operate the patient with recurrent disease, then first of all guidelines state that it's mandatory to do an FNA for cytology and preferably also for thyroglobulin measurements of suspected lymph nodes in order to prove that they are malignant before surgery. And it's very important, and this is something that both reviews stress, that you need to define with the patient. You need to speak to the patient and define with them, what is the goal of surgery? Am I going to cure you? Am I going to reduce the risk of future recurrence? Are you going to live longer? Or am I going to reduce the risk of local complications? And all these need to be taken into consideration. And another very clear-cut recommendation is that there's no more any place for berry picking as we used to do, of excising only the affected lymph nodes. Rather, you should be performing compartment-respecting surgery. So I've shown you what we know, what we think we know, and now for my last slide, I want to show you what we don't know. So I mentioned twice that extranodal extension, which is defined as the presence of disease spread outside the lymph node capsule into the fat, skeletal muscle, or any other tissue surrounding the lymph node. And this entity, which is a pathologic entity, only after the lymph node has been excised, we can say if there was extranodular extension. And by the way, the American College of Pathology has introduced it as a compulsory part of the report of a pathology report of thyroid cancer where lymph nodes were excised. You should mention if there was E&E or not. I don't know how many of the institutions in Israel have this as a routine. But we know from the literature that the presence of extranodular extension represents an aggressive phenotype of well-differentiated thyroid cancer. And there are different publications showing that the rates of future distant metastasis are higher, the risk of recurrence is higher, and there's worse disease-free survival. So we should know about this by all means. So in this study from the group from Mount Sinai, first author is Alpert et al., and last author is the author of one of the reviews. They looked at 83 cases of differentiated thyroid cancer where the pathology report included extranodular extension. And they looked at the size distribution. They asked themselves, is this something that we only see in large lymph nodes, or could it be at any size? And surprisingly enough, they found that 47% of these lymph nodes that had extranodular extension were less than 10 millimeters in size. And I remind you that according to the new guidelines, some of these lymph nodes would have been left behind because they're small and they're benign. And they also found that there was no correlation with the actual size of the metastasis within the lymph node and the presence of extranodular extension. So it's not all about size, and we actually may miss extranodular extension by observing small malignant lymph nodes and not know that our patient has another risk factor for a more aggressive disease. So with this, I want to finalize. I've shown you that there was a paradigm shift in the treatment of regional recurrence for differentiated thyroid cancer, and I don't know where we'll be in 10 years, but I think this question is relevant to many of the topics that will be and were discussed this morning. Definitely there is a need for a prospective randomized study with long-term follow-up of 10, 15 years and more to show that there is any disease-related survival benefit of early surgery. I think that maybe consortiums such as the Thyroid Cancer Care Collaborative may give some retrospective data because they will have large numbers from a lot of patients. And I think that in this clinical scenario, specifically of this patient who was a low-risk patient, had no features of an aggressive disease, has some kind of persistent disease after 1 year, there is no one right answer to the clinical dilemma. And I've shown you that not all metastatic lymph nodes are born equal, and every patient is unique and different. And therefore, this stresses the importance, and this is, I think, the take-home message from both reviews, of the need of a multidisciplinary team that should help the patient understand the benefits and the risk of surgery versus watchful observation. And with this, I will conclude.